I'm Dr. Rick Greene from the medical school class of 1970, and it's indeed my pleasure to host this series of our outstanding faculty at the University of Virginia School of Medicine, and it's really a pleasure today to talk to a friend and fellow board member, Dr. Randy Canterbury. And Randy, it's just a pleasure to have you with us today.
Well, thank you, Rick. It's a pleasure for me to be here.
Now, I know you've recently transitioned, but we're going to talk a little about some of our past here. And I always like to start off, you were a young man from West Virginia. You went to medical school in West Virginia. How did you get to the University of Virginia? What brought you here?
Well, it actually was quite a happenstance, I would say. At the same time that I was graduating from high school, excuse me, from medical school, Will Spradlin, who was the chair of psychiatry at WVU, was leaving to come to UVA. And he had started a program, a residency program in Morgantown that was a dual internal medicine and psychiatry residency. And I wanted to participate in that, and so I applied to that and a couple of other residencies as well. But he said to me, called me in his office one day and he said, listen, I'm leaving WVU and going to UVA, and I would like for you to come and be the first resident in the dual program at UVA. I want that to become a signature program, and I would like for you to come. And so it took about 2 minutes to decide to do that because my wife grew up in Stanton and had always wanted to move back to the Charlottesville area. So we made that decision, and the rest was, I guess, history, as they say.
Well, it's like a coach changing schools, taking a star quarterback.
Well, I don't know about a star quarterback, but he did bring me here, and I have never had a single regret, obviously. I've loved it here.
So you're double boarded in internal medicine and psychiatry. What has that meant to you to have that internal medicine background as well as the psychiatric background?
Well, I would think clinically, it put me in a pretty unique position. You know, initially I practiced internal medicine 40% of the time and psychiatry 60% of the time, and I did that for quite a number of years. And then when I became the chair of the psychiatry department, I learned that I couldn't do it all. And so I gave up the internal medicine formally and continued on in psychiatry. But I would say that my patients utilized me to a great extent for health information, if you will, because they felt like they were seeing their primary care physicians for 15 minutes and not able to get their agenda on the table, not able to ask the questions as thoroughly or get thorough answers like they would like. And I spent 30 to 60 minutes with all of them. And so they started to utilize me quite a bit to get their questions answered. And of course my background in internal medicine helped a whole lot. I didn't get in the way of their primary care doctor, but I did a lot of translating for them. And so I think that it also helped me because I practiced so much at the interface of medicine and psychiatry and saw a lot of patients in intensive care and so forth. So I also got boarded in psychosomatic medicine, which is consultation liaison psychiatry, and that really is it's psychiatry and cardiology, it's psychiatry and hematology oncology, it's psychiatry and transplant medicine and so forth. So I think it was excellent preparation. I'm not sure people would have to do 2 residencies, but it certainly is something I don't regret and enjoyed, in fact.
So a third-year student who wants to go into psychiatry today from the University of Virginia School of Medicine, what are you advising them? Should they follow the track that you did, or think about something else in psychiatry? So
I've always told, I've advised lots and lots of students who were enamored with the idea of medicine and psychiatry together. And what I said to them, to all of them, was that obviously I have a passion for that, but that you really do have to have a good reason to do it. It's pretty tough to do 2 residencies in 5 years. Long hours, I guess the hours are not as long now as they used to be, but long hours and a lot of stuff to digest. And So I just always told them, think about it. Is this something you really do? You have a career path that demands this. If not, maybe you should think about a more traditional route.
So let's talk about your other passion. Your other passion has been curriculum change. I think everybody is aware of the next generation curriculum, now a version 2. I think that started about 10 years ago now. And tell me a little of your thoughts, and I know there's so much to talk about there, but what is the 2 or 3 major things that curriculum did for our medical students that probably they wouldn't get at another medical school?
Well, I think what we do, the next-gen curriculum is becoming more standard across the country. I would say that they would not have gotten it at another medical school 10 years ago or probably even 5 years ago, but a lot of schools are now adopting the model. But the major changes, I would say, I guess are really threefold. In version 1, the initial version, it was the idea of eliminating all those courses that we took in medical school that competed with each other. And professors in 2 classes might say to read 200 pages tonight, and so you have 400-page assignments in physiology and biochemistry or whatever, pick something, which was very tough, And what we did was to figure out the foundational science that was necessary to the understanding of medicine and teach from the patient care perspective, and then the foundational science will underlay that. And so we did the integration for them, which actually reduced the amount of seat time that they had, allowed them more time for independent study, to more active learning rather than sitting passively listening to lectures. We would engage them in problem solving, whether those were clinical problems or scientific problems or whatever they might be. So all the evidence says that when you learn something by using it or by applying it, you're likely to remember it, understand it better, and remember it better later on, and be able to apply it in novel situations, which is, of course, what doctors do every day, all day long, right? The patients don't come in with a sign on the chest that says what's wrong with them. They come in with sometimes ambiguous kinds of symptoms and so forth, and we have to solve a problem. And so that's what we tried to create in the classroom setting. So the integration, the active learning, and I would say that the thing that version 2 has added to that is more emphasis on the idea of demonstrating competence over and over and over again, so that we and the students become confident that they do have the clinical skills necessary to practice medicine.
So again, getting away from the siloed approach that I experienced as a student, more integration, interoperability.
Absolutely.
That's marvelous.
Absolutely.
That's marvelous. So let me ask you a little about your interests now after you're transitioning, because I think knowing you're never really going to get away from medicine, and I know some of the things you're doing.
Yeah.
You're doing some surveying for the LCME. USMLE. I want to ask you specifically, because I've been on the USMLE Step 2 committee. USMLE Step 1 is going to a pass-fail system. What are your thoughts about that? Is that good or bad?
I think it's a good thing, and I advocated for it for about 20 years. What I learned was that medical students, when we reduced our curriculum to just 18 months, the pre-clerkship curriculum to 18 months, students started checking out at the beginning of the 3rd semester. I mean, they literally did not come to class. Out of 156 students, there might be 35 or 40 in the classroom. Okay, well, active learning doesn't really work very well if you don't have anybody present, okay? And they were watching podcasts. Okay, well, podcasts are like lectures. That's not active learning. So it was really destructive to their learning when they checked out of medical school, basically, and spent all of their time in the library memorizing stuff for USMLE Step 1, which they took in February or so. So, I thought, that just doesn't make any sense. I mean, it's illogical. And then if you think about the exam itself, it was being used primarily by residency training directors to decide who gets an interview and who doesn't. The score on that exam is what determined that. Of course, it's not that kind of an exam. It's a licensure exam. It's a minimal competence exam. And when you get beyond what has been determined by the experts to be, well, you know about this, you've done standard setting, I'm sure. When you get beyond minimal competence, the test starts to lose its validity. And so it was being used for something that it wasn't designed for or scored for, and it was basically just, in my opinion, ruining the learning that students should have been doing in the classroom.
Well, outside of all of these things with LCME and USMLE, what are you looking forward to doing outside of medicine?
Well, I have a home on the Chesapeake Bay, my wife and I do, and we have 2 boats there, neither of which has been in the water for 4 years. Because there was just not time to do it. So it is my plan to either rejuvenate those boats or get rid of them and get a new boat, but we want to get back on the water some. What else am I going to do? I don't know. I probably will do some volunteering because that's something I always felt like I didn't have enough time to do. I did do some, but it was always a challenge. And so I think I decided to take some time off, though, after I retired, to reset, and for my wife and me to reset, because it's different. It's very different. She's continuing to work. She still loves working, and so I'm a house husband right now. I do a lot of cooking and some cleaning, and keep myself occupied, though.
Well, Randy, we didn't have time to get into all of the things that you've done for this medical school, all of the distinctions you've had, but I certainly, from my standpoint, I want to thank you for just being an absolute marvelous representative of what's so good about the university and its medical school, and thank you for everything you've done for all of our students.
Well, thank you. It's been a pleasure. I've enjoyed every moment of my career.
Today we've been talking to Dr. Randy Canterbury, and again, it's been my pleasure to host him for this Medical Alumni Series. Randy, thank you.
Thank you, Rick.